Thank you for joining us for the fourth in our webinar series on building an effective brain health program. Let me introduce you first to our speakers for today, and then they will introduce each other. Kathy Lamberti, the founder and CEO of SMARTfit Inc., has over 3 decades of experience in developing innovative technology that bridges cognitive and physical performance. Her evidence-based gamified dual-task programs empower users of all ages and abilities to rapidly transfer skills to real-world scenarios. Ryan Glatt is a PhD candidate and director of the Fit Brain program at the Pacific Neuroscience Institute in Santa Monica, California. He's the author of the American Council on Exercise Brain Health Trainer program and has authored several white papers on brain health and dual task training for different populations. He also serves as a brain health programming consultant for facilities across the U.S. Dr. Rob Winningham is a neuroscientist and professor of psychological sciences and gerontology at Western Oregon University, with over 30 years of researching human memory and the brain's impact on human performance and quality of life. He's the author of 2 books, Train Your Brain, How to Maximize Memory Ability in Older Adults, and Cranium Crunches, and is a frequent speaker at industry events. We'll get started with Kathy. Thank you.
Hi, everybody. Thanks again for joining us on this fourth presentation. Our goal is to build a comprehensive program over the months so that not only you, but your staff can always refer back to them for training and retraining and bringing on new staff. We also are pioneering something fairly new here where we are developing a technology that captures the relationship between cognition and movement. And this is a new field for most of us. And I'm just honored and excited to be part of this movement. I think it's a super important one. We call it movement-based brain health. And I think this is really one of the areas we all need to be focusing on when it comes to brain health. Keeping it simple from my point of view, let's see if I can get this to move. Technical issue here. There we go. It's very simple. When I look at it from my point of view in providing a solution for our customers, what is the role of assessments? Number one, I think it's critical for engagement and motivation. When someone can see how they're doing, they tend to stick with the program. And I've noticed that in physical therapy, doing physical therapy post-surgery, not knowing whether it's working or not, just having some data there really does make a difference to improving retention. Refining progressions as well. The data can help with just making sure that clients stay in the learning zone. I think it's really important that they don't get bored and that we don't overwhelm them. So we use the data to make sure that they are sufficiently challenged. And then finally, the proof of success. This is where it gets real exciting when an organization like Axe Living and Ryan Glatt put a study together over a number of years. And then congratulations, Ryan, on your publication last year to this study. I think it's super exciting. And I'm just so pleased to be part of that program too. Finally, I'm just going to show you how it can be simple and it can produce wonderful results starting simple. You don't have to overwhelm your organization with too much too quickly. You're going to get a very good exposure today to what the possibilities are. But I also encourage you to keep it within the scope of your business, remembering it's about retention. If people practice, they will create new neural pathways. So this is what we want to focus on, keeping it fun, keeping it engagement, and keeping it evidence-based. So I'm going to play a short video just as an example of one of our customers achieving wonderful success.
In March, the Bay County Council on Aging started some new classes to help improve clients' cognitive skills. The classes are part of the council's brain health program they started 2 years ago. As News 13's Jared Sellers tells us, staff members are calling the results, noting nothing short of remarkable.
Around 7 million Americans suffer from Alzheimer's disease. 2,000 of them are in Bay County. The Bay County Council on Aging's Brain Health Program tries to slow down and even reverse memory loss. Clients use something called a SMARTfit board, which helps them remember patterns and test reaction time. Brain Health Program Coordinator Lynn McCrory says the results are mind-boggling.
The statistics show that every person, and that is phenomenal for me to say because the data shows that every person that has been through the Brain Health Program has significantly improved.
The council is currently conducting its 5th class. At the beginning of the 6-week period, clients are tested. The normal reaction time is around 6 seconds. By the end of the class, the average reaction time drops to just 1 second.
It's really interesting to see that once they play the first round of the games, they're like hooked because they don't even realize that in the perspective that they're actually improving or working toward the improvement of their cognitive and motor skills because they're having so much fun interacting with the system.
In Bay County, Jared Sellers, News 13, Panhandle Strong.
The next class starts in November on the 7th and ends December 14th, but there is a waiting list, so call for more information.
So that's just an example of how you can keep it simple and still have it highly effective. So with that, I hand over to the experts who will take you deeper. Thank you.
Thank you so much, Kathy, and thank you everyone for being here today. Rob and I are so happy to be here and be sharing this information on assessments and creating personalized brain health prescriptions. We're just going to glaze over our bios because Kathy, you did such a great job there in the interest of time. And Tom, you as well. Thank you for that. So we'll start with why assess. What is the purpose of an assessment? Why should we even consider having any kind of assessment? One of the reasons to create an assessment process is whether we're looking at implementing a brain health program that's inclusive of dual tasking and extra gaming or cognitive activities, or even just managing your existing physical activity and cognitive activity offerings to be more specific, is to select appropriate activities. I hear from clients and patients all the time that people went to an adult daycare program or a YMCA class, or they hired a trainer and it wasn't appropriate. Either it was too hard, too easy, it didn't really speak to their goals. Perhaps maybe it just didn't really fit their preferences. And so the selection and suggestion of appropriate activities, whether it's a class or even a specific exercise of picking whether we pick a calculation-based exercise versus a verbal fluency exercise. So that's one key purpose of an assessment. The other is grouping individuals by similar level. I hear all the time from Parkinson's clients of mine that they go to a specific class and they didn't feel like they were challenged enough because the overall average of the class was too low. Or and certainly we can have mixed populations, but when we have individuals with dementia, with individuals with memory concerns, but they're completely normal, you typically wouldn't put them in the same class. And so one of the other purposes of assessments is to group individuals by level. And also determining their physical and cognitive capacity. A common complaint I hear in the programs and the people I work with and the trainers that we train is that they picked an exercise that the individual couldn't do. And you can't really be mad at the individual because if it's beyond their capabilities, or it wasn't explained well, or it's just, they have a certain level of dementia and the activity is too complex, we can't be upset at them for that. So assessments can help us determine this. We also use assessments for motivation and gamification to identify goals, preferences, and values that the individual has. Identifying opportunities for referral. Assessments can be very helpful for referring out for anything from sensory changes like vision or hearing changes to a neurologist or a neuropsychologist or a rehab clinician for further evaluation. And then establish baselines and demonstrating progress, and of course, measuring change over time. So these are all reasons why we might have an assessment. And so from the purpose of program management, we might be thinking just to show change, but an assessment can be used really as a behavior change tool and also as a tool to build an allied healthcare professional network. So assessments are not simply for demonstrating change. And we also want to be thinking about the person that we are assessing, not just the assessment. So these are all great reasons to consider an assessment. And here are some considerations for doing assessments. If we're going to use assessments, not every assessment is created equally, and we're going to be learning about that. So you all probably heard about this idea of causation versus correlation, which I wouldn't really need to explain. Did we improve because of other factors, or was it a direct factor? Practice and learning effects. This is the one thing that I think people confuse for maybe diagnostic information, is that when we're taking any kind of test, that certain tests need to have their psychometric properties researched. And Rob will be talking a bit more about that in terms of what psychometric properties look like in certain cognitive tests. But the entire field of neuropsychology considers things like practice and learning effects, as do any psychometric properties of any test, physical or cognitive. There's also strategy dependent changes. If we're doing a dual task assessment, is the person focusing on the cognitive, focusing on the physical? The psychology, are they very anxious? Did they really hear the instructions? Were there any sensory issues of understanding those instructions? Was the person anxious or hyperactive or super focused on a particular aspect? So there's a whole psychology of testing. So if I told any of you in the audience that we're going to be getting a 4-hour neuropsych evaluation of your cognition, how would you feel about that? Some of you would feel different. Some might be excited, some might be interested, some might be very anxious, and some would never talk to me again if I told you that. So everyone's got a different psychology around testing. There's also the placebo effect, and also attribution bias. If people did show an improvement on an assessment, what was that due to? And especially because there's this popularity around multimodal programming, which we're going to talk about, all these different lifestyle interventions, from dual task training to sleep hygiene education interventions to nutritional interventions. How do we really attribute what an improvement was due to? So we don't have straight answers for all these things, but these are the things that I think about, and I know Rob thinks about when we're looking at assessments and whether we're evaluating a program or a research study. These are things to keep in mind. We also talked about psychometrics, and psychometrics are kind of aspects or properties of an assessment to consider. And there's a few things you may have heard before. We're going to review them because I think they're important to understand when selecting assessments. Are these valid? Meaning, are they accurate? So validity is the accuracy of a measure and to the extent which a tool measures what it is intended to measure. Reliability, also referred to as consistency, is what is the consistency or stability of a measure over time? And so if I remeasured that person an hour later or a week later or a month later, is that a reliable measure, or is there a lot of variability? Sensitivity, can it detect a change? And so some people use certain assessments that are not sensitive enough to show a change, and they'll use them to bookend maybe 12 weeks of programming, and the assessment itself, didn't show a change, but then the trainer or the therapist and the individual feels like there is. So some assessments are not sensitive enough to detect those changes, and then some assessments are so sensitive there might be some variability. And then specific. This is typically in regards to diagnostics, but maybe correctly identifying those without a disease, condition, or ability. And most of the stuff we're going to talk about can be, but typically is not diagnostic in nature. They're usually performance-based measures of mobility or balance or cognition. But specificity refers to the ability to identify those with or without a condition, typically. And then repeatability. Does short-term, same operator, same tool, same setup, is there some sort of repeatability to that? Kind of, does it produce the same result if everything was the same? If it was a different trainer or a different therapist or in a different place or a different time of day, how would that affect the scoring of that assessment? So these are all good things to keep in mind. It's a lot to keep in mind, but it really helps with this, what I would call productive skepticism of how we're evaluating and interpreting this assessment information. Now let's get into types of assessments, and we'll start with physical assessments. I'm going to assume the majority of you here today come from a movement background, fitness, wellness, physical therapy, things of that regard. And you may be coming from other backgrounds as well, but let's start with some physical assessments. We can, of course, look at balance. That could be dynamic balance, or that could be static balance. We can look at gait or walking. That could be how an individual walks, the quality. It could be the speed as measured in timed up and go. Strength as measured by things like a 30-second sit to stand or bicep curl test. There's endurance measures, whether it's a 2 or 5 minute walk test or a sub-maximal VO2 test. Dual task ability, which we'll be talking about specifically when it comes to the timed up and go dual task condition. and agility. How does someone respond in terms of a gross response in relevance to a stimulus, in response to a stimulus? So these are all different types of assessments. And sometimes we only look at one. And I think many of us are familiar with the senior fitness test that popularized having more than one, where there's the 4-stage balance test and the timed up and go and a 30-second sit to stand and a 2-minute walk test. And it's not that you need to measure all of these, but the more we measure, the clearer of a picture we get about a person and how we might be able to help them and also customize their programming. And so when it comes to assessments, we usually want to start with a primary assessment. What is the overall goal that the person has? Maybe what is the goal of a program? Are we suggesting that the program can improve balance? Is the goal of the individual primarily to improve balance or walking or fall risk reduction? And based on that, we'll pick a primary assessment. The primary assessment should be well validated, well researched. We want to lead with something that we are confident in, others have used, and we know there's all those psychometric properties that have been researched. And this could be like, for example, a timed up and go. Then we want to pick a secondary assessment. Maybe this is relevant to a secondary goal. And so let's say an individual, their primary goal is balance, but they would also like to improve their strength, but if they had to pick one, it would be balance. Or let's say it's a secondary cognitive goal or a quality of life goal. The short-term goal they have maybe for the next, let's say 3 to 6 months or 3 to 12 months is balance, but the overall goal they have is quality of life. Well, then we can incorporate other things like balance assessments, gait assessments, strength assessments, whether that's lower extremity strength and strength endurance or grip strength, and even things like questionnaires. And these are things that still have some evidence, maybe not as much as the primary, maybe as much as the primary, but we're bringing them in as sort of a secondary goal based on what's important to the individual and what's important to the program. And then we have exploratory or tertiary assessments. This is typically things like within system testing. So game performance might be an unvalidated but motivating way to show changes. Maybe it's a dual task assessment specifically within the system. So if we're talking about SMARTfit, which we'll talk about a little bit more, we wouldn't only do a dual task cost assessment. We would do that within the system, and we do a dual task assessment outside the system. And we want to be able to do that to show transfer and just cover our bases and make sure that we have a clear picture on what's going on. And usually these are performance-based measures, and maybe it's a new thing that's been researched lightly or hasn't been researched at all, but it's exciting. We want to bring that assessment to the forefront. But because we haven't had strong validation studies, we don't want to only offer that. We want to basically do our own informal research study on each individual or program and combine it with well-validated assessments with exploratory ones. Let's also introduce cognitive assessments, and Rob, feel free to jump in. We have global cognitive screeners, things like your MoCA or Montreal Cognitive Assessment, your MMSE, your SLUMS. We have questionnaires. These could be subjective cognition questionnaires, subjective memory questionnaires, quality of life questionnaires, mood questionnaires, cognitive reserve questionnaires. There's many different kinds out there. Pencil and paper neuropsychological testing with a neuropsychologist or speech therapist. There's also computerized cognitive screeners. There's many on the market now, like BrainCheck or CogniView. Computerized cognitive batteries like CNS Vital Signs and Craos and things like this. And then pencil and paper domain-specific testing that Rob will be talking more about with us.
Well, I'll just kind of jump in. And by the way, just great introduction to this topic. I loved your discussion of the psychometric properties. And want to just kind of pulling on that string a little bit. I do worry a little bit about our global screeners, because if we are giving, I'm going to go through a lot of these tests. If we're giving the SLUMS, the St. Louis University Memory Scale, too regularly, you could imagine a situation where they're getting that on a quarterly basis. If we do that, that test is going to lose validity when they do that for their annual physical exam with their healthcare provider. So I think we want to be mindful of these tests, how often we use them. I worked with a company where we did testing in maybe 100 different communities, and we did it annually. But we had to still be kind of mindful of the fact of doing these tests over and over again. We could lose some validity. I also just like to just talk a little more about why we should assess. I suspect if you're here, if you're listening to this, you're thinking about doing assessment, you are doing it, you want to refine it. In addition to the things that Ryan had mentioned, it also helps us figure out where we need more resources, particularly in a senior living environment. If we're seeing that we need more strength training, and a lot of communities that I visit, they're not doing enough strength training, in my opinion. And if we're kind of weak on that, we might want to add a strength training class or modify a water aerobics class to facilitate that. So I think it can be really helpful, particularly for senior living communities, in that context. And go to the next slide. So, the cognitive testing, and one of the things I want to say is we have a lot of different tests, and I'm just put into the chat a Google Drive link that's open if you have the link. I will keep this open for a month or so. So go in, you can download these tests. I put in 10 different tests in here that I frequently use, largely in the kind of the senior living space. The first one that I have put in there for you is the Montreal Cognitive Assessment. And I kind of view, if we're thinking about the previous slide, somewhere between, kind of more of a global screening tool and a neuropsych test is kind of where I would put the MoCA. It's a little more than the quickest screening tool, but it's not as long as the longer ones. And kind of building off something Ryan, was saying earlier in terms of validity, we actually get greater validity and greater sensitivity on the longer tests in general, when we think of neuropsych. If we just give a 2 or 3 minute cognitive screening tool, that's not the test that you probably want to use to see if your program is going to lead to a change. It was too short to be sensitive, and thus it's lost some of its validity. The Montreal Cognitive Assessment might be a little better there. Some other tests in the upper right-hand corner there is part of the trail making test. That is one of the most commonly used tests to measure executive functioning in the literature. And it is a little more sensitive, even though it's fairly short. So in that sense, I think it's a really good test. Excuse me. And that's in the Google Drive folder I shared with you. And the trail making, what you do, and there's some good instructions there. You start with Trails A, which is, I would refer to that as more as setting a response. In Trails A, we're getting people to respond a certain way. They go from 1 to 3 to 4 to 5 to 6 to 7 to 8, and so on. And that gets them thinking 1, 2, 3, gets them counting. Then we go to the second part. After we have set that response, now they need to inhibit and be flexible. And rather than going 1 to 2 to 3, they go 1 to A, 2 to B, 3 to C. So it's a great measure of mental flexibility and also attention. It turns out your score, your time on the trail making test has been shown to predict your chance of falling. It's even been shown to predict safety in driving. Occupational therapists will often work with people to assess their safety driving, try to improve that. And one of the best tests to do that is actually the simple trail making test. It actually maps pretty well onto the functions of driving. We've also have up here the Stroop test, and I have Stroop A and B in that folder. Similarly to the trail making, we set a response. So Trails A, you're supposed to state the color of the font, but the font always matches the word. So the word red is written in red font. So a lot of people are just reading the word, which after we set that response, we go to Trails B, they have to inhibit rather than reading the word, which is now a different color than the font's a different color than the word. They're going to still try to read the word. They have to inhibit that and state the color of the ink. This is challenging for people because reading has become automatized. It's a procedural memory. It's actually in a different part of your brain where we do it very automatically. It doesn't use much cognitive resources. So we have to inhibit reading and state the color of the ink. So like that word red there, we don't say red, we're supposed to say orange. And that would be part of the Stroop B. Norms are important for this. Many of these tests have norms. I did include the published norms in the folder for the trail making test. And if you go into that article, you'll see how our time to complete, particularly Trails B, but also Trails A, it goes up over time. And so you kind of see where you should be for the decade of life one is at. But Ryan said something really important earlier that I want to highlight. Even if you don't have specific norms for the tests and the assessments that you're using, you can always do the pre and post test, where you see how well did you do compared to last time you took the test. And so a lot of tests can be used, a lot of assessments can be used that way as well. But to go through, just to kind of mention everything that is in the folder, that kind of put a lot of these are kind of under cognitive testing, but many of these kind of fall into other aspects of wellness. If I think of the International Council on Active Aging, their dimensions of wellness, they include intellectual, physical, social, spiritual, vocational, emotional, and environmental. And many of these tests that I'm sharing with you kind of fit into these various buckets. We certainly have the cognitive, that would be the Montreal Cognitive Assessment, the trail making test, the Stroop test, and I also put the slums in there. That's going to be the closest thing to a global screener. Be careful on that one because that's the one that the nurses and the doctors are going to probably be using with your clients on a regular basis. We've also put in 3 different Centers for Disease Control tests, part of the STEADY program. And Ryan had mentioned these. I put in the 4-stage balance test, the timed up and go, and the 30-second chair stand. And so those are directly from the Centers for Disease Control. They're well validated. They're used a lot. And I'm less concerned about the test retest impact on validity for these tests. Once you kind of learn how to do it, but you're going to need to improve your physical functioning to get better after you've learned how to do it. So those I would be less concerned with doing more frequently. And I put in some other tests that you might not have expected to see, which fit into some of these other buckets. So I'm glad we have quality of life up here because I did put in the most commonly used quality of life scale. If you're kind of doing a comprehensive battery of tests, it's a great opportunity to kind of facilitate some conversations about other aspects of wellness, often related more to emotion and mood and perceptions of that. Similarly, on the social aspects, I put in the UCLA loneliness test, which is also good because, particularly in the senior living environment, we have many programming opportunities for people that are feeling lonely. And loneliness has been shown to have a fairly direct impact on physical health outcomes. So it's something to consider. And I also put in the ADL Advanced Directive. So ADL are activities of daily living. Once again, particularly in the senior living environment, we can kind of see where people are at. And this would be helpful if somebody is already developing some cognitive impairment and we can figure out how they do various activities. So lots to go on there. Do you have anything to add to this slide, Ryan?
Yeah, I would say like there's other things that I feel are very much related to brain health in general, quality of life and mood exceptional, determining potential loneliness and things like that. Uh, Attitudes and beliefs. There's some great research demonstrating that positive age-related beliefs have an impact on dementia risk. Uh, a lot of people want to know the adherence to various brain healthy lifestyle behaviors such as sleep, nutrition, exercise, and things of that regard, various other determinants of health, and also asking what doctors people are currently seeing. A lot of people might have a cognitive impairment and have never seen a neurologist, or it's not really our role to tell them or kind of write a recommendation or referral, but to ask, have you had your hearing or vision evaluated? Is something that a lot of people have not done on a regular basis or at all. And these simple things are very much related to dementia risk. And so I think, we don't want to overwhelm people, but we do want to see from where we stand how we can best serve them through these different assessments.
Those are really wise comments, Ryan. The one thing that I would kind of add to the determinants of health is health literacy. And I don't think we talk about this enough, but there's a body of literature that is showing one of the determinants of our overall health as we age, and even when we're younger, is our health literacy. And this is why it's so important for professionals to be up to speed on these issues, because if we can inform our clients and our residents about these various issues, I mean, why should we make these lifestyle changes? What's the impact? How does it affect your goals and what you want to do in life? Having your clients be up to speed on the types of things that we're talking about in the SMARTfit webinar series can help motivate them. And that's another important determinant of health. And I also just want to amplify something that Ryan said about getting baseline testing. I mean, if you don't remember anything else from this webinar today, please remember, if you're talking to somebody that is concerned about themselves or their loved one for cognitive impairment, one of the most helpful things to do is get baseline testing. It might just be a global screener to get a baseline on that. It might be a 2-hour neuropsych battery, but that is incredibly important for figuring out what's going on. Because if you just have one test in time and you compare it to the norms, we say, oh, you're for 50 percentile for your age. That means you did better than 50% of the people your age on that test. That doesn't tell us much. We might say you're doing well, but what if that person had been 90 percentile? 10% of the population is, and now they're down at 50 percentile. Something is going on. We should intervene. We should give them options before it's too late. So having that baseline test allows us to go back and track the course of the disease. That's also incredibly important for diagnosing the type of dementia or the type of problem that we're having. So the most important thing you can recommend is to get baseline testing. So another aspect, and this really ties into SmartFit and some of the great features SmartFit has on assessment, is dual tasking. And we've talked about this before in other webinars. And dual tasking is the concurrent performance of two tasks that can be performed independently. We can measure them separately and they have distinct goals. So dual tasking is not the same as doing a really complicated, complex single task. So carrying a cup of water, backpack, and suitcase, that's actually all kind of one task. However, combining tasks, pouring or drinking water from a bottle while walking, now that's dual tasking. Those are two separate tasks done at the same time. Or opening a backpack while walking. That's an important example because one of the reasons we often see particularly older adult women fall is they will be walking, they'll look into their purse, focus on that. That's dual tasking, and then they fall. And we can increase people's capacity to do two things by training them in dual tasking, which SmartFit has the best set of activities to do that. And we can train it and we can measure it as well. Go on to the next slide now. So when we do dual task cost testing, we have people do a single task. Maybe that for an occupational therapist, that might be having them put on a button-down shirt. Then we have them do another single task. That might be cognitive, counting backwards by 3 from 100 or something else similar. Then we have them do both, put on the button-down shirt while counting backwards. And if you go to the next slide, that will give us the dual task cost. That's what you'll see in the literature. What was the cost to the person in terms of their performance, measured as time to complete, the number of reps, how accurate they were, whatever it is? What's their dual task cost when they do two things relative to doing just one? And so once again, you can see an example there. We'll do a single task physical. We usually start with the single task physical just so people can recover from that physical activity. It might be a walking test. Then we do a single task cognitive, serial subtraction by 3 or some other cognitive test. And then we have them do both. And we see how much is their performance degraded doing both compared to doing one. Next slide. And that's how we get the dual task cost calculation. We measure dual minus single divided by single times 100. Next. So in this example, we were going to see Kathy, who we saw earlier, do physical only, cognitive only, and dual task. So we'll start watching this now. Now she's doing the physical only. So we're balancing. We'll see if she loses her balance, put her foot down. We'll call that a fall if she does. And no, she doesn't. So perfect performance. Now she's doing a cognitive task, knocking out numbers of a certain sequence, which was explained to her beforehand. And then we have her do both. And let's see if she has to put her foot down in the second one. Yep, there it goes. See, initially on single task, she wasn't doing that. And so we can look at that performance there. Put this all together, we can say when she did the dual task, her points on that was 20 minus 30 that was the point she got when she did the single divided by 30. And so using these metrics, we would have 20 divided minus 30 is 10. It would take the absolute value. 10 divided by 30 is 33%. We have a 33% dual task cost there. And that is important. Now we got a baseline. So, if somebody wants to improve from that, we're going to give them dual tasking activities, exercises, which SmartFit has a lot of them, more than I've ever seen before. And this is something that Dr. Studer and I help them create. And then you can exercise it, come back to it. But the nice thing about SmartFit, it gives you a report. You'll get a report of what the physical cost was, the cognitive cost. We often will do the cognitive accuracy cost and the cognitive reaction time, and we can see how well they're doing on these. So it's nice to have that report to come back for. It's saved.
Thank you, Rob. And I think one of the great ways to collect and track these things, whether it's a timed up and go, a dual task within the SmartFit system, perhaps a questionnaire, is we have to collect and track these things. Ideally, if we want to be able to show that there's changes or be able to use these things to group individuals. And so many of you might have access to electronic medical records or an assessment template. For example, I used to work on our clinical side where we had access to Epic and we had different templates. And now we work on the foundation side where it's more wellness based and fitness based. And so we have things like Healthy or a mind body type platform where we still have notes and templates that are HIPAA compliant. So you might have your own system internally for doing this. And you want to make sure, once again, that's HIPAA compliant because technically speaking, this is health related data. And a lot of people will use Word documents, Excel spreadsheets, PDFs, pencil paper that gets scanned in or stored securely. And it must be organized, transcribed, and secured. And I remember in my early days, I was not doing this well. And, when it came to seeing if they've gotten better, it's, where is this paper and is this secured properly and things like that. And so it's very important to have this in order and know, is it going to be primarily electronic, written, or a combination of both? And then I think it's also helpful to consolidate scoring into a single document for quick reference. For example, internally, if you want a copy of this, you can email me. But I have a spreadsheet where I have all the primary baseline and post program assessments, and then using these spreadsheet or Excel measures to automatically calculate the percentage difference, and then also doing that for every type of assessment. And so that would be one example of consolidating the scoring into a single document. And then you can use this information to also create progress reports that you can share with allied healthcare providers. So when the referring neurologist or nurse practitioner that referred the client to me or participant to me is asking, hey, how is this person doing? I can share some of that information with them, and they usually appreciate that very much. If you're also looking for more assessments, how-tos, lists of assessments, maybe normative data or research, the Shirley Ryan Ability Lab database is exceptional and has the majority of these assessments we've talked about available. Physiopedia is also another great resource, especially for learning how to do these assessments, because I know many of you have questions about the operational aspect of how to do these and how to learn how to do these properly, what you say, what timing in what timing or environment that you do it. CDC or Center for Disease Control that Rob mentioned, MedBridge, and I know that Rob and Mike both have various courses on MedBridge that are excellent resources for learning how to implement some of these things. And I know there's many assessments there as well. In terms of a recommended intake process, we suggest that you kind of pick a brief screening tool. And so we talked about some of the differences between screening and outcomes. Screening is not necessarily to show a change, but more so to screen them to see if they're appropriate for the group, which group they should go into, and maybe how to personalize some of those activities. So some of those global cognitive screeners can be helpful. It's helpful to ask if they've had one, because a lot of people might present with a high cognitive reserve and be very good socially, where you can't quote unquote tell that there's any problem. And that's, subjective observation is very important. But sometimes we are having a conversation with someone, we put them in front of the SMARTfit, and we're like, oh, maybe there's more cognitive impairment than we thought. And so screening tools can be very helpful for that. It doesn't feel good to be tested and kind of poked and prodded on the first date. So we want to be very cautious about the test psychology, and we want to build some trust and rapport and ask for permission to do these screeners before we get into those. Then we do sort of a basic intake. This can include a basic medical history, a PAR-Q plus, maybe some of your assessments, and a collection of what's kind of going on with this client's health history. It doesn't need to be a copy of their entire medical records, but it's good to know if they have a history of orthostatic hypotension, so that if you're having them do a timed up and go, or you're having them do a 30-second sit stand or certain exercises, that under pressure and distraction and physiological demand, that they don't get dizzy and fall during your assessment. So you want to know those things. You don't want to be surprised that they have knee pain in the middle of your session. So we want some of that basic information. And optionally, but helpfully, is to collect information about the client's lifestyle factors. What's their sleep like? How are they sleeping? Have they seen a sleep doctor? Do they have a potential untreated sleep apnea? Because it's very difficult to show improvements in, say, cognition or balance when you are fighting against an untreated issue, like an untreated mood issue or an undiagnosed mood issue. And often an undiagnosed issue is an untreated issue. And so many people have an untreated sleep apnea or hearing deficit or vision issue. And so I had a client that I took in, this was probably 3 years ago, and they were having a lot of trouble with visual scanning on the SmartFit. And they were having much more trouble than I would have expected for their MCI diagnosis. And so I asked him, I said, Danny, have you had your vision assessed? He said, oh, yeah, I'm fine. I have these readers. I'm like, well, where did you get those? He's like, oh, at the checkout at Rite Aid. I'm like, well, that's not what I'm talking about. I'm seeing some issues in the way you're playing these games. I'd just be curious if you would talk to your doctor about getting your vision checked out. And turns out he had significant vision problems that are now treated and at least diagnosed, that we know, is this really a vision problem, a cognition problem? And yes, it's both. But that's one example of why it's important to understand what's going on with them health and wellness wise. Outcome measures. This is where we're picking our specific set of physical outcomes: timed up and go dual task, sit to stand, 2-minute walk test, 4-square step test, whatever the combination of those things are, as well as the cognitive outcomes, whether it's any of the things that Rob has shared with us today. Maybe it's a subjective cognitive questionnaire. And we're going to talk about scope of practice and how to determine what you can offer and what you should offer. And unfortunately, everyone has a different situation. But fortunately, it gives a lot of creativity and flexibility of how it works in your environment. We'll talk a little bit more about scope of practice. And then finally, we want to combine all that with exploratory assessments. So assessments that are very exciting, very interesting, perhaps very new, but haven't yet been researched psychometrically as much as other things like a 30-second sit to stand have. And like I said, every different outcome serves a purpose. And so not every assessment will do all of these for you. And while it's true, the more you collect, the more we can help people, we also don't want to burden people or burden our staff with a giant stack of paperwork to get through, right? We don't want to replicate the feeling of being the DMV, but we do want to educate staff and clients and participants and patients about the benefits of certain assessments and be realistic about how many we're incorporating. And sometimes staff has a lot of time to do assessments, and sometimes there's no time to do assessments, it feels like. So we have to consider the resources that are available to us. Now let's use that information to conceptualize this idea of personalized brain health prescriptions. And I don't like the word prescriptions because it's not a real prescription, but it's another way of saying we're going to hyper personalize and make specific these types of offerings and interventions. Before we get to that, I do want to talk about scope of practice, and I'm going to talk about scope of practice from the perspective of the fitness professional. And there is a bit of gray area that we'll talk about, but the goal of the scope of practice of a fitness professional is to receive guidelines from physicians, therapists, etc., and implement those things within our scope of practice. So if a physician, like most of my referrals come from a physician, and so if a physician refers someone to me, I'm using their guidelines on whatever was in their after visit summary on nutrition and exercise and things like that. And I'm not disagreeing with them. I'm saying, yes, I see that the physician recommended this program to you, as well as these other things. And we're going to follow up on those things. And other questions about personalizing, we'll go back to the doctor or the neurologist in this case, or physician. Or if you have questions about nutrition, even if I'm passionate about that, and I listen to many podcasts and read many books, I know my scope of practice and when to refer to a dietitian or nutritionist, for example. We also screen for limitations and identify potential risk factors. We refer clients to allied healthcare professionals or medical practitioners. And when I say refer, I don't mean make the referral. What I mean is encourage the client to speak with their doctor about getting a referral. And then we design exercise programs and we document progress and we report that progress to allied healthcare professionals. And we empower individuals to use this information to begin their programs for guidance, support, motivation, lapse prevention strategies, and feedback. You want us to add something to that, Rob?
Yeah, I think and I'm kind of coming up more from the perspective of senior living, and I've shared a lot of those tests with you. And Ryan said there's kind of some gray area here. Some people could disagree with me sharing all of those tests just widely like that, and I'm a little more liberal in that. But the one thing that I want to say is please avoid any, unless it's within your scope of practice and you're licensed to do this, please do not say anything that sounds like you're making a diagnosis. That's critical. Right now, my students and I are doing a study. We're giving people living with dementia the slums test. And I've instructed my students, and I've done this with other studies, that they're going to want to know, how did I do? And all the students can say is, you got some questions right, you got some questions wrong, let's move on. And it's awkward to say that because you kind of might want to go back, but you might be getting too close to diagnosing, and you definitely want to avoid that.
Absolutely. I completely agree. And I think, as a fitness professional that's also a medical exercise professional, before we implement any cognitive assessments, and assessments is a light word too. So assessments can mean something different to you than to a client than to a clinician. And so if you say, hey, I did these cognitive assessments, and they're like, you did what? We want to avoid that, right? And we also want to check with other people in and adjacent to our organization to ask what they think. If I'm working with a neuropsychologist, like I work under a neuropsychologist, I work in tandem and adjacent to speech therapists and occupational therapists. I'm not going to need to do anything that they're already doing. But if you're working in an organization where there's really none of those clinical services available, and you want to just do a stopwatch time-based test like the trail making to see how quickly they connect the dots, just to see a speed measure, and you're saying it not as a diagnostic, even with normative values, which is for you, you are using that as a performance-based measure, even though other people might use that as a diagnostic tool. So it's very important to draw that line. And then once again, we want to recognize what's within scope of practice and always refer clients to other healthcare professionals when appropriate. And also we want to consider your liability. While it's very important and rational to want to help people, we want to recognize that our scope of practice is very limited, typically, and we want to stay within it so that we can serve others, but also protect yourself. And some of the preventable dementia risk factors I think are helpful to know about. We can talk about dual tasking all day, but if we're not addressing these factors as well, I believe we're doing a disservice to those that we serve. And this is from the Lancet Commission in 2024. Hearing loss is a massive preventable dementia risk factor. I'm often begging people to get their ears and eyes checked out. Vision loss as well. high untreated LDL cholesterol, untreated hypertension, air pollution exposure, smoking, obesity, diabetes that's untreated, physical inactivity, which is well within our purview, depression, alcohol consumption. This is in regards to excessive alcohol consumption. Depending who you ask, might be any alcohol consumption and social isolation. And so I even have, it's informal, but I kind of have a mental checklist of this. And I'm not asking about every single one. And I'm assuming that their doctor has addressed the majority of these things, whether it's at an annual Medicare visit. But I always ask, when's the last time you had your hearing and vision checked out? And if they say 5 years ago, the light goes off. And I say, maybe you should speak with your doctor because it can really affect your brain health. Hearing changes can affect your balance, your memory, your socialization. Vision can directly affect our sessions here and things like that. And of course, we're talking a lot about physical activity in my sessions, and some of it's coaching intermixed with dual task training. So just because they come to a dual task training session or a brain health program doesn't mean we don't address these factors. It doesn't mean I can't speak to them about these things within my scope of practice and during the rest breaks or before they leave or right before we start. We're doing these check-ins about talking about these things. And of course, there's some health coaching behavior change strategies that we don't have a lot of time to get into today because we don't want to just be telling people what to do and ordering them around and having them be closed off because most of these people that we might be working with are already being told to do all sorts of things they don't want to do. So we want to be cautious of that. And some of these general exercise recommendations, you've heard the 150 to 300 minutes, but according to some of the research I've read, about 80% of older adults are not meeting those guidelines, and that's at a moderate intensity or greater. There's, of course, additional benefits for neuromotor training and strength training, as well as more minutes of exercise. And multi-domain exercise programs seem to slow the progression of cognitive decline more than shorter single modality programs. Now, why am I showing this to you? One, you've probably already heard this, especially if you've heard me talk. But one of the reasons I'm showing this to you is because dual task training is just a subset or a type of neuromotor training. But neuromotor training alone is not enough to try to do everything we can to prevent dementia from an exercise standpoint. We want to make sure we have enough minutes. We want to make sure we have enough intensity. We also want to do strength training. We don't want to say that dual task training is much better than strength training because they have differential benefits on brain health as well as the body, and they do other things. And dual task training can't deliver on all the things that need to be done. It can't deliver on, can outperform the cognitive benefits of treating sleep apnea or even exercising to these guidelines. So it's important to keep that in mind. And the elements of a brain healthy exercise program, again, are that 150 minutes at least, which is 2.5 hours a week, moderate intensity or greater, or anywhere from 2 to 3 to even up to 7 times per week. We want a combination of aerobic resistance and neuromotor. And this is where dual task training can help us, is that we want to incorporate open skills, things that are unpredictable, as well as direct cognitive demands, and design for enjoyment, which exergaming and dual task training can certainly help with. So how do we personalize a dual task training intervention then? Well, we got to think about the physical tasks we're doing with someone, the cognitive tasks that we select, and the setting, the goal, and the environment they're in. Are they in a group session? Are they in a one-on-one session? What is the goal that they have? Do they want to improve balance? Do they want to improve memory? Maybe both. Well, let's take an example. This is a very common example I have. An 83-year-old woman with balance challenges. She's worried about falling. She has memory concerns, and she's very anxious about her performance. So the physical task I might select might be a dynamic balance task. Maybe she's nervous about stepping side to side while I'm giving her a cognitive task, then maybe we start with a static balance task, even if that's just standing. And a lot of people don't think that just standing and managing posture and managing postural sway is a dual task. But for someone with a balance impairment, relatively speaking, it very well may be. And then once they're safe and they feel good about that, maybe I can introduce a dynamic balance task. And then maybe I'm picking a specific memory game. But what if that memory is related to attention, especially given her anxiety? So maybe I do a matching exercise where there's lots of visual scanning. Give her a sense of mastery. The cognitive task isn't too complex. And she has to remember the instructions and remember what she saw as she's scanning. And maybe that could be a nice warm up leading into a memory exercise, especially if she's particularly anxious about that. And maybe the goal is complete the task for time while managing anxiety, and or just taking as much time as she wants and not being anxious about it. So this can serve as both exposure therapy for how to interact with the task while not being anxious, while still being challenged, and practice going fast while not being anxious, almost like we would in sports psychology. And so that can be one example of how we might personalize it for an individual. There are also many acute variables to modifying your programming based on the assessment data you're collecting. The physiological intensity, how hard is it? Is this person marching in place? Are they stepping over a hurdle? What's the cognitive complexity? And a lot of the time I hear people say, oh, I picked a game and they were so frustrated that they couldn't do it. Well, in my head, I'm asking, well, why did you pick something with greater complexity? There's never a problem with starting too easy. There's often a problem with starting too hard. We can always increase the demand. And so when I give a demo or a tour or the first introduction, I always pick games and tasks that I know everybody can do, even if they have a form of dementia. And so we want to keep that in mind. It's so much better to have it be too easy and progress than have it be too hard and regress because of the psychology of it. We also want to consider the speed of the task. Is the goal to sequence the numbers in order as fast as possible, or to sequence the number in order while making as little mistakes as possible? So keeping in mind this accuracy speed trade-off. The psychological context, which I think we spent a good amount of time on, and the duration. Are we doing just a 20, 30-minute set, or are we doing a set for 3 to 5 minutes? How many sets are we doing? Are we doing just one for 30 seconds and moving on? Should we do more to give someone a sense of practice and mastery and improvement? Do we return to it right after, or do we give them a break by doing a separate task and then coming back to it? All of these are important questions to ask. And then what's the goal of that task? What's the domain of the task? And what is the gamification element? Are we trying to beat a score? Are we trying to just do it while feeling good about ourselves? Are we trying to manage the physical task without stopping? What is the main goal of that? And does it always have to be about score? And so based on this, there's various ways to structure our sessions. As we spend a lot of time on, we start with this pre-program assessment. Then we might focus on things from weeks 1 through 8 to 12, let's say, increasing in complexity over time, just as we would with a resistance training program. So let's say we start with basic attention and speed exercises on weeks 1 through 4. And then weeks 5 through 6, we get into choice reaction. Weeks 6 through 8, impulse control and executive functioning. Weeks 9 through 12, really dialing up the complexity on working memory and cognitive flexibility and visuospatial skills. And of course, you don't have to withhold a specific task from someone, especially if they're getting bored, they want more variety if they can handle it. But the idea is, like with resistance training, that we have this idea of progressive overload, but instead of weight, we're talking about cognitive complexity. And then, of course, maybe after 8 to 12 weeks of that programming, we might reassess. It doesn't have to be 12 weeks, but the average duration of a session we found in the literature seems to be about 12 weeks. And of course, you can continue thereafter. I have people that have been training with me once a week for maybe 2 or 3 years. And this is just to show that we can increase complexity over that period of time. And as Kathy was saying, we're very excited to have published this study last week in partnership with Asbury, where we were able to find that this brain gym type program, in as little as 8 and averaging about 24 sessions over the course of a year, significantly improved cognition, specifically global cognition and processing speed and executive functioning. And different measures were used. The timed up and go was used. The timed up and go dual task was used. Different SMARTfit tasks were used. There was also the use of CNS vital signs, which is a computerized cognitive assessment system, as well as using things like the MoCA and even a subjective memory questionnaire. So this was very assessment intensive. And that's something to keep in mind, is that as we do something like this, we have to keep in mind staff demands. And so the staff was not just responsible for collecting those assessments, shout out to Don Kirk, but also running these interventions, which is a very challenging thing to do. And so we'll be sharing this study in our follow-up, as well as Rob's link to the Google Drive. But this is something that this is kind of the first study to show using a combined approach in an outpatient brain gym program that we can detect these changes in cognition, which is consistent with previous dual task and extra gaming studies. So what's required in order to do this? First and foremost, I think the thing that is most important is staffing. Staff is usually something you already have, but making sure the staff is on board with assessments, trained in assessments, and has the proper understanding of what to do, even showing them this webinar at the minimum. And making sure there's a level of education, whether it's getting certified from the SmartFit Academy, taking MedBridge courses, taking ACEs courses, things like this, getting the programming, having the equipment selected, and of course, as we spent a lot of time on today, having assessments and also having the right partnerships. As we also discussed, there's a lot of things that are important when considering implementing these assessments, and having those allied healthcare professional networks is really critical. And you don't even have to be the one doing those assessments. I know many people I talk to who have physical therapists, occupational therapists, and speech therapists perform the assessments, and then they just provide the programming. So you may not even have to do them yourself. There's a lot of ways to outsource them to nursing staff, rehab professionals. For example, there's neuropsychologists here and rehab clinicians, so I don't really have to do a lot of assessments because they've already been done. And so there's many things that can be done with partnerships. You do not have to do all of this yourself. With that said, Rob, if there's anything you want to throw in there, please do. These are our respective emails, and we will be sharing the slides, the Google Drive link, as well as the new research paper that just came out last week with all of you, and we'll pause for Q&A. Rob, while I bring up that Q&A, is there anything you'd like to add?
Yeah, I don't think so. I was just thinking about the Q&A. Jane had asked a good question about, what types of activities do we have that exercise dual tasking, and even kind of called out Brain HQ. A lot of and maybe Ryan, you could help with this answer. And it would be a good thing for us to list in a future webinar to just list all of the different types of activities. I don't have a list in front of me,
Absolutely.
but we do many of the things that we exercise the abilities that matter. So what we tried to do when we built the dual tasking, we have lots of different physical activities that can be done, so you can just imagine all the different physical exercises that can be done. And then we want to pair those with different cognitive abilities. And on the training side, we've really tried hard to focus on executive functioning. That includes attention, inhibition, mental flexibility, reasoning, because research has shown if we improve executive functioning and training, that can generalize to things that haven't been trained. When people have better executive functioning, they're more likely to be independent, less likely to fall, better driving ability. So we have tried to adapt a lot of the things that we knew targeted executive functioning. So we have things based on the Stroop effect, for example. We have things, kind of related to visual scan, knocking out numbers while we're counting backwards. A lot of things related to executive functioning, really similar to Brain HQ. And the reason these different products are so similar, because we all kind of need to exercise executive functioning with a wide variety of activities so people don't get bored and we get greater generalization. So I'm going to make a note, Jane, to try to add kind of a list of our dual tasking activities in a future webinar. I think it'll be an impressive list.
I agree. And just to elaborate on that, the active studies Brain HQ game is called Double Decision. And basically the way that game works is it flashes a car and you need to see what kind of car it was in the middle, while in the periphery there's a Route 66 sign and you have to see what segment it showed up on. It'd almost be like looking at a SmartFit device at the middle target. It quickly flashes while something also flashes in the periphery. And so there isn't any exact brain game like that within SmartFit, but there doesn't need to be, because that specific game I think is really interesting, but it's really challenging both vision and processing speed. And a lot of the types of training that's done within SmartFit, as well as many of these dual tasks and extra games, is processing speed based. And so there are many ways to train that, even if it's not the exact game. So great questions. If there's any other questions, we're happy to stick around for a couple more minutes. If not, you're welcome to leave the webinar. And thank you so much for your time and attention in joining us today. And we hope to see you on the next one.
Hi, everyone.
Thanks, everyone.